you can see, Simon Jones. I'm a paediatrician from Manchester, from the Willink unit, and we're one of the designated UK centres for the treatment of Pompe disease. I'm a paediatrician, so most of my patients are infantile, with a few juvenile onset patients. It's clear that many of you in the audience either have adult onset, later onset Pompe disease, or have family members who do, or who work with later onset patients. So I'll try and explain a little bit about the differences in infantile onset disease. And then, there we go. Go through a couple of cases which have caused us some challenges, and how we've tried to think about those challenges, and what the future might hold in the treatment of infantile Pompe disease. You're all aware of this, so I'll skim through this. Pompe disease is a disease with many names, and you know about this as well. Pompe disease is essentially a disease of the muscle, as you know. But in infantile Pompe disease, one of the differences from adult onset, or in fact later onset disease, not just the age of presentation, but that the heart muscle is an integral part of the disease. Cardiomyopathy, a great word which we doctors use to try and sound intelligent, simply means disease of the muscle of the heart. It means nothing more than that. So infantile disease, we've seen from some of the registry data, in our experience, usually presents between the age of about 4 to 8 months of age. That's when we often say it as doctors, not when the symptoms first start, which is usually much earlier than that. The symptoms that parents come to us complaining of, and as a paediatrician, you're always taught, listen to the mum and dad, they know, are generally poor feeding, breathlessness, and floppiness. And generally at the time of presentation, most children will have significant cardiomyopathy, so their heart muscle is diseased. And in general, and in fact almost always, that is hypertrophic, so the muscle is swollen and grossly enlarged, and often not pumping as well as it should do. And untreated, before we had Myozyme, before the current era, the historical cohort of patients taught us that, and when I say untreated, I mean simply enzyme replacement therapy. These patients got a lot of intensive cardiac and often ITU support. The patients, despite all of this, gradually deteriorated and died before 18 months of age, which is the oft-quoted number. In our experience, it was usually much earlier than that, and often within just a few months of diagnosis. Okay, so treatment. The original trials of Myozyme, as you know, were done in the infantile group, and there were 2 clinical trials of enzyme replacement therapy, which were compared against historical controls. It was deemed to be unethical to pick up an infantile Pompe patient and not give him treatment when a treatment was possible. And so we knew from our historical cohort what happened to you if you had infantile Pompe disease with significant cardiomyopathy. And those trials both showed prolonged survival in the treated patients. Generally, and in the majority of cases, there was a very good response from heart muscle. And in the end, although this may take many months, the heart muscle, in most cases, normalized. However, there was a variable response seen from skeletal muscle. And I think this is an important issue, which I'll come back a little bit to later. And we know this. Some patients remain ventilator dependent, despite being on treatment and despite their hearts improving. And we think that some of the variation in that response seems to relate to how early the treatment was started. And that appears to relate more to skeletal muscle, i.e. the muscles that move your skeleton around, rather than the heart muscle. And there's a difference in response and a difference in how those muscles react to the glycogen storage within the lysosomes. Please stop me if I say anything that is just sounds crazy or you don't understand. Okay, you all know this. Enzyme replacement therapy, now available. Myozyme is a recombinant form of the human enzyme that is deficient in Pompe disease, produced by standard recombinant DNA technology. And the standard dose, 20 milligrams per kilogram by intravenous infusion every other week. And funding in England, being specific there, is directly from the Department of Health via a national commissioning group, the NCG, special body which is set up to fund and coordinate treatment centrally, given the costs of treatment. Now, most of you will have known all of that. I want to go through some specific cases which we've struggled with recently and which show different aspects of infantile pulmonary disease.